Hello, today we're discussing acute coronary syndrome's role of percutaneous intervention. We're going to go over the key trials. PAMI was the initial trial in 1993 comparing PCI versus lytics, showing a significant combined reduction in the endpoint, 6.5 versus 13.9. Gusto 2B compared lytics versus PCI, 30-day composite endpoint of death, repeat infarction was significantly lower in the PCI group, 9.6 versus 13.7. Danish multicenter trial, transfer for PCI versus on-site lytics showed a large benefit for patients transferred to PCI center compared to those receiving lytics at a local hospital. Now here are the references. If you look at the PAMI results overall, the angioplasty group had a reinfarction rate of 5 compared to 13 for the TPA group. The overall death was 5 compared to 13 for the TPA group. And non-fatal reinfarction or death was 10 compared to 24 with a significant p-value in favor of the PCI group. The definitive study was Gusto 2B, multicenter randomized trial, urgent primary PCI versus TPA for STEMI patients presenting within 12 hours of symptom onset. PCI significantly reduced death and non-fatal reinfarction at 30 days. This trial established primary PCI as a preferred reperfusion strategy. The primary endpoint of death and non-fatal reinfarction was 9.6% for PCI versus 13.7% for TPA, with an odds ratio of 0.67. Disabling stroke wasn't different. The 6-month composite outcome was not different between the two arms. The Dynami trial had referral hospitals and invasive treatment centers. The primary endpoint was 8.5 PCI versus 14.2 for the lytics. In the referral hospitals, p-value of 0.002. In the invasive treatment centers, primary endpoint 6.7 PCI versus 12.3 in the lytic group, p-value 0.05. Overall, patients had the benefit driven by a lower reinfarction rate, 1.6 versus 6.3. 96% of the patients were transferred from referral hospitals to PCI centers within 2 hours. Primary PCI outperformed lytics across community and invasive centers, mainly through a marked reduction in reinfarction. This is an important finding. Here is the survival curves in the dynamic trial. When you compare real-world data with 2008 as a baseline, in 2012, the odds of having mortality excluding cardiac arrest was 0.75 compared to 2008. So over the years, there was significant improvement in the community. When you look at door-to-balloon time and mortality among patients undergoing primary PCI, over the years, again, the median door-to-balloon time significantly dropped from 2005 to 2008, with the mortality level being maintained. The rival trial compared radial versus femoral access, and it showed that in high volume centers, the hazards of having a complication were lower with radial compared to femoral. In STEMI patients, the hazard ratio was 0.6 in favor of radial access. Benefit was confined to high expertise centers and the STEMI cohort. The 30-day composite death MI stroke endpoint was similar. In the Matrix trial, again, where they compared radial to femoral access, the major adverse cardiovascular events were 8.8 for radial, 10.3 for femoral, with a significant p-value. Net adverse clinical events was 9.8 for radial versus 11.7 for femoral, with a significant p-value. The drivers of benefit were BARC major bleeding non-CABG, 1.6 versus 2.3. If you went radial, the risk of a major bleed had an odds of 0.6 compared to femoral. All-cause mortality, 1.6 in radial versus 2.2 in femoral, with a relative risk reduction of 0.7, significant p-value. When you look at utilization rural versus urban, rural hospitals have significantly lower catheterization compared to urban hospitals and lower PCI rates. Then now we deal with the STREAM trial results. In the STREAM trial, patients underwent fibrinolysis followed by urgent cardiac cath followed by PCI with a median time to angiography of 17 hours. Emergency angiography was required in one third roughly of the lytic group. This showed that pre-hospital fibrinolysis followed by timely coronary angiography achieved effective reperfusion, and pharmacoinvasive strategies therefore supported by this trial. When you compare lytics to primary PCI, there was no significant difference. Mortality in this trial was 12% for fibrinolysis and 14% for primary PCI, higher than the other trials. When you look at the control arm of these trials, it's very interesting. In 1988, the control arm had a mortality of 13%. In 2013, the STREAM trial had a mortality of 5.9%. And here's the mortality in the treatment arm, 8 versus 4.4. If you compare the 1988 finding of 13.2 in the control group to 8% in the active treatment group, goes to show how much aspirin and lytics do for you. Whereas the STREAM trial emphasizes that early aspirin lytics followed by cardiac catheterization and PCI within a median of 17 hours gives you a further reduction by about half of the expected mortality. Thank you for watching. Please check back for future videos.